We're going to talk about now a couple of the strategies that we're going to use for initiation of the 3100B onto some of our patients from conventional mechanical ventilation. In our policy and procedure manual, each one of you has a copy of this in your mailbox. You'll have a copy of the policy and procedure. You'll also have a copy of the checkoff that you're going to be responsible for accomplishing, beginning with our clinical competency starting tomorrow. So you've had this for a month. You should have gone over it, and there shouldn't be any real questions about it. But we're going to go over right now the initial setup and what you would do to put initial ventilator settings if you're transitioning from conventional mechanical ventilation to high-frequency oscillator, the 3100B. As far as oxygenation is concerned, your mean airway pressure is going to determine your oxygenation. This and your FiO2, which is set on your blender. So you're going to set your mean airway pressure on the oscillator to begin with at 5 centimeters of pressure above what your mean airway pressure was on your conventional mechanical ventilation. So in this case, if we had a conventional mean of say 22 or 23, then 27 or 28 would be appropriate to start as a mean airway pressure. As far as our amplitude is concerned, we're going to set our amplitude to get a chest wiggle between our clavicles, which would be here, to our mid-thigh. And you need to be able to see the patient actually moving this far. A great place to start would be just to start at an amplitude of about 90. I know that sounds kind of high, but you really can't think of it in terms of centimeters of water pressure as much as you think of it as chest wiggle. You want to see that patient moving from their clavicles all the way down to the mid-thigh. So a good starting spot for this would be about 90. You'll want to set your bias flow at 40 to begin with. I know that in the calibration procedure and the on-patient procedure, we had it up to 30. It's going to require more than that from the majority of your patients that you're going to be dealing with. So you want to set this up to about 40 liters per minute, and that'll give you a little bit of leeway on your mean pressure adjust. So you will set this at 40. Initially, we're going to set our inspiratory time at 33%. And according to our policy, what we're going to do as far as hertz are concerned is we're going to get a blood gas and we're going to set our hertz as far as our blood gas is concerned. So if we have a pH of 7.1, we're going to set our hertz at 4. If our pH is 7.1 to 7.19, we're going to set it at 5. And if our pH is 7.2 to 7.35, we're going to set it at 6. And if it's greater than 7.35, we're going to set the hertz at 7. This is a good way to start initially the frequency that you want for your high-frequency oscillator. After that, we're going to continue to reassess the patient, and we're going to normalize our lung volume, and we're going to want to see our chest x-ray. We're going to see lung expansion between 8 and 9 ribs, and we're going to make adjustments on our mean airway pressure for our oxygenation issues in increments of 3 to 5, and we're going to make changes in our amplitude in increments of 3 to 5 to control our CO2 or PaCO2 on our blood gas. We won't be able to do end-tidal measurement on CO2 with the oscillator. The flows are just too high for that. But if you have transcutaneous monitoring available, that's a great way to monitor your PaCO2. So those are some initial things that you can do to transition from conventional mechanical ventilation to the high-frequency oscillator, 3100B.
Jim, can you go over compensated for a cuff leak?
Compensating for an ET2 cuff leak?
Yeah.
One of the things that what Scott is talking about, we can have an ET2 cuff leak, and sometimes we want that. Sometimes we'll actually let some of the air out of the cuff. That is one of the strategies that we can use if someone's retaining CO2. What we can do if someone does have a leak in their cuff, and it's something that we can't help and we don't really want, is we can increase our bias flow. Is one thing that we can do to try to counteract a cuff leak. We can go up on our mean a little bit, but you know, if you have a really bad cuff leak, what I've seen as far as our pediatric patients and PICU is concerned, you probably ought to consider changing out the ET tube. One other thing that I wanted to say and wanted you to remember, when you use any of our ventilators, you always want to make certain that you have an inline suction catheter. And I've seen this happen before where we've started an oscillator on someone and had to stop and break the circuit to put an inline suction catheter in place. And when you break the circuit on one of these, you de-recruit. So you have to make sure that you have that ready and have everything ready ahead of time so that when you start the oscillator, you're maximizing lung volume right away.